So the standard premaxillary setback procedure or technique is, this basically: you incise the midline of the elongated premaxillary neck. You create bilateral mucosal flaps up to the septal margin. You do try to elevate some flaps along the alveolar ridge. You do an ostectomy right anterior to the premaxillary vomerine suture, and then you do a wedge resection of the anterior caudal septal cartilage. And here's an anatomic drawing. You can see this is that suture right there, and you basically want to do it a little bit anterior to it. Of course, this is not a bilateral cleft. And then here is kind of a schematic illustration of a wedge excision of that cartilage, and then you basically retrograde the projecting premaxilla backwards. You inset the premaxilla back into the alveolar arch, and then you close the gingival perioplasties if you've done that. So here's the idea. This is not a setback, but this is kind of the idea about taking this projecting premaxilla and sending it back into the arch with your retropositioning. So John Mulliken put this article out back in 2016, and again, a lot of this talk is also echoed in this article, and I would urge you to read this article if you're not familiar with it, where he, of course, in his usual very careful and scientific way, went out and measured what were the results of these children after they've had this procedure done, and did it really have the effects that it was purported to have based on future growth. So if you look here, he tried to compare a setback with a Latham, and if you look, basically you'll see the intraoperative numbers are not very different between the setback in terms of these alar width, the Cupid's bow width, the filtral height, and then he looked at them serially, which meant that he looked at them further down the road in terms of allowing them to grow, and he found that essentially there were not very many differences between doing the Latham and doing the setback. So, the Latham is a very labor-intensive thing. You have to have an orthodontist. You have to actually screw the device into the bone. You have to actually remove it at some other point. So it's a much more sort of labor-intensive type procedure. So now I'm going to bring out some of my Rogue. This is the Rogue's gallery, 2-month-old, and here he is 3 months after his repair, and he is dehisced. And this patient, I didn't see him because he's from West Virginia, and I lost follow-up, and then he came back, and this is what happened. So I had this problem, and he had healed his lip behind this projecting premaxilla, and so this was the first time that I actually did this, where I was able to inset it back in again. And I was very concerned about how this segment would be dealt with later on. But again, I was able to deal with that problem through the amazing help of an orthodontist. So here he is, and it turns out that he had a craniofacial cleft as well, and may have probably contributed a little bit to his problem, but you can see that I was able to get the lip repaired, and this time it healed. And here you can see that premaxillary segment. It's not in a terrible position, but of course he did need to have further orthodontic work for better arch alignment. This is a patient that you kind of see when you go on these mission trips, and they are older. This was one of the children that were adopted and brought to the United States completely unrepaired. And if you kind of look from the side there, that premaxilla is essentially sticking straight up. So, you can try to fool yourself into thinking maybe this is something that you can repair, which is what I tried to do. And that was my repair. You can see that there was just a tiny little piece of filtrum there. And this is what I got at the time of the surgery. A lot of people talk about it being released widely, both laterally on both sides, and you can almost close anything. But I think that that's maybe not necessarily true in all cases. Anyway, so this happened about 2 months afterwards, and you can start to see that pressure from that projecting premaxilla has really caused dehiscence there. And here you can see in the operating room the little piece of vomer that is holding that piece of the premaxilla. And here I've done the osteotomy here, and I've actually, there's not a piece missing there. I've just levered it back to prove that it was as mobile as I needed it to. And then through the wonders of my orthodontist, I was able to, here she is now, obviously her lip is healed, and that segment right there did take a huge amount of creative manipulation, and I'm just going to quickly, because we have a little bit shorter time, just kind of go through. You can see gradually how that arch is now kind of realigned, and now this was the most recent picture where the arch profile has now been restored. So at that point, she's ready for bone grafting. So what are the trade-offs? We can do an immediate closure of a bilateral cliff lip deformity now, and realizing that many of these patients are going to need orthodontic surgery later on. So I think that in some ways the trade-off is worth it in the sense that you can get their lip closed. They can go on to live an early life that was sort of free of having the cleft, and then later on, knowing that with your work with your orthodontist, you're going to need probably some orthodontic surgery. So in conclusion, I would urge everybody here to re-examine things that you've been taught, because they may not necessarily turn out to be true. We certainly have much better standards of follow-up assessment and looking at levels of evidence. And so I think you ought to, as a service to your patients, re-examine all your previous dogmatic thoughts and maybe think about things outside the box. Thank you very much.
Thank you, Dr. Lynn. Next we have Dr. Ali Totonchi from right here in Cleveland, and he's going to talk about one stage versus two stages down there.
Good morning, everybody, and thanks for the invitation. I'm also going to be talking about the alveolar bone grafting and some timing aspects of it. As much as the anatomy is simple in the alveolar area, but this is a complex issue to deal with. As we know, alveolus is a cavity, and the dental alveolus is basically the tooth socket and maxillary alveolar process. Embryology, we all know, it's a lack of fusion of the frontonasal process with the lateral palatine process as well. The reasons we have to do the closure, one is that basically to support the tooth that is coming out. Which tooth usually come out? The canine is the most important one, and sometimes lateral incisor also might be affected, coming to the cleft area, or might be just next to that closure might save that tooth as well. The timing of the eruption, as we look at the canine area, is about 11 to 12 years, and the lateral incisor is about 8 to 9 years of age in the kids. Again, the ideal time for the repair is going to be when the permanent tooth is coming down. So if you are saving the tooth number like a lateral canine or lateral incisor, so we need to do it based on what tooth we are expecting to come down before 8 to 9 or 11 to 12 years of age, based on what we are trying to support. History of the alveolar bone grafting, it's been mentioned a little bit. First is done in 1901, but it wasn't successful, the first one. The first successful one was done in 1914, which was a tibial bone grafting at the time. Then Wu did another series of reports which was unsuccessful in 1931. Going back on in the craft care by Millard, he mentioned that overall there's not an enthusiasm among the cleft surgeons to do the alveolar bone grafting. But time went on, and in 1950s to 1960s, people started doing primary grafting to early month. Early month meaning by weeks or month after surgery. In 1961, there was a report of a 3-stage repair. Again, it was very early on, and going further on, the most cited and article by Scoop, which he mentioned we are doing this procedure for the reason of maxillary stabilization, and he advocated doing the primary repair, primary bone grafting as well. And this study, this series of primary bone grafting literally went on all the way to 1970s. At the time, there was some concerns came up. So what the problems were at that time, which pushed the people to shy away from doing the primary bone grafting, was multiple articles came up. One of them, people also used to use a rib graft, and they found out that the tooth doesn't go through the cortical bone, so they had to stop that. Then there was a bigger study, 10-year follow-up on the patients with the primary alveolar bone grafting showed that people might get restriction of the midface by Wehrman, and also they showed that although we are doing this based on screw to stabilize the midface, but we are not getting any midface stabilization. And also they showed that people might get malocclusion. Interestingly, there's a recent study in 2017 showed that primary bone grafting does not limit any maxillary growth, which was interesting to me, but it showed that it is ineffective method of maxillary stabilization, which was one of the primary goals to do the primary bone grafting. Secondary bone grafting, then it is basically it's done at the time of mixed dentition time. Main reason to do this at the time is to help with the tooth eruption. Again, we talked about which tooth we are trying to save, and also closure of the fistula, and also maxillary stabilization. Technique, like anything in the plastic surgery and specifically cleft care, there's no consensus, but there is a nice article in 2007 published in Journal of Craniofacial Surgery which explains this pretty well, and they talk about having a pyramid as a defect in the alveolar area. Okay, so they describe the defect as a pyramid over here. So the lateral walls of the pyramid is the two sides of the bone. Basically, this is something that we are hoping this bone grafting is going to heal to. So those structures are there, so we are not repairing anything over there. The nasal part is the top part of this pyramid. This is something that we need to get a nice closure on. The bottom part is going to be the palatal part. The anterior part is the alveolar segment, anterior part of the alveolar segment. Any of these three areas, if we don't get a good closure on that, of course the bone is not going to heal nicely. You're going to get contamination and bacterial growth, and you're not going to have good blood supply and bed for the bone healing. What they recommended at that time, basically, as we discussed, a nice nasal layer closure, nice palatal layer closure, and they put the cancellous bone in the cavity, and they created the flaps to close the area. The one thing at that time they did, they also put a cortical bone in the sides to cover this area a little bit better, which makes sense to some degree of protecting the closure, because not all the time we have a good vascularized tissue in the nasal layer, palatal layer, or anterior wall in the gingivolabial sulcus to close it and provide a nice vascularized bed for the bone take in that area. Although you can argue that those bones might also injure the mucosa and cause some fistula as well. In terms of the type of the bone grafting, people have used cortical bone. The cortical bone, as we know, they don't have like active cells, and there was a long time for the cells to come in, or the vascular tissue to come in and have a vascular growth. On the other side, doesn't help the tooth eruption, because as we discussed, some of the studies showed that the tooth doesn't pass through the cortical bone. Cancellous bone is going to be our best option, because they have active cells, helps the tooth to come down, and also by having active cells, the properties of osteoinduction and osteoconduction is there, so they're preserving that. In terms of the sources, so many articles out there. Most of the people use iliac crest by Anand article, as we discussed before. Craniofacial area, mandible, mostly done by oral surgery colleagues. Tibial bone graftings, one of the first reports. Rib, again, is not a useful source for the bone grafting, since most of it is cortical. And there are recent studies by Dr. Urada's team from demineralized bone plus BMP, and allografts from Dr. Losi and Dr. Kumar. The second bone graft study, this is a study I mentioned from Dr. Urada's team. They had a good two articles which followed each other in 2017. They went through 501 cases in the first study, and they compared the efficacy of the bone matrix with BMP versus compared it with the secondary bone grafting. And they came up with the conclusion that using the BMP with the bone matrix is a safe alternative and does not increase the adverse reaction. In the second article, they went even one step further, and they studied the quality of the bone, and they said that there was a comparable bone growth and density in both groups when you're comparing the bone matrix with BMP compared with the secondary bone grafting. Allograft also is a report, as we talked about, by Dr. Losi and Kumar, but this was for the failed bone grafting. And they also conclude that safety and efficacy of the allograft, they showed that it's safe and efficacious in that area. There are some in vitro studies, but also 3D printing and dipping it in the mesenchymal stem cells, which again, it's a work in progress. The risk factor for failures, there are so many articles again showing the failure with the age, with the dental quality, but most of the people, they focus on the bilateral one. If you have bilateral one, they have a higher rate. There are a couple articles on that. Dental agenesis and the gap width is the biggest one that is going to cause the failure if you don't address that before surgery. If you want to get this done in one stage and don't encounter the complications or bone loss, there are few studies going over making the gap smaller. So we talked about the orthodontics, we talked about doing pre-surgical NAM or anything that brings the segments together for the future. There's a study also published in 2010. They did 11 patients with a distraction osteogenesis in the transpalpebral area to bring the gaps together and make the cavities smaller. Also, any type of closure in the area that is going to keep the segments together is going to help with making the gap smaller when you're doing the bone grafting. Like a gingival periosteoplasty is going to make the gap smaller. It doesn't let it grow. I've seen Dr. Hossein doing the alveolar closure at the time of the cleft palate repair. It's like a gingival periosteoplasty, but at the level of, at the time of the cleft palate repair, which is also going to keep the segments together when you're going to do the alveolar bone grafting, so you will have the segments closer to each other. There was an article also recently from 2017. They did a reinforcement of the under the mucosa. If you remember those pyramids that I showed in the previous slides, you reinforce under those mucosas. You reinforce under the gingival sulcus above the palate with the scarpa fascia, which by this reinforcement, you are going to decrease the chance of dehiscence and the bone graft loss. And I also have some experience using Alloderm, very ultra-thin Alloderm, where the tissue is not coming together. Like when you are opening the nasal layer is not coming together, specifically the ones that are not set up right. Then you have to close that area somehow, otherwise you're going to have some contamination and the bone loss. There are two reports in the literature I found from the two stage, and both of these articles are for bilateral procedures. Bilateral procedures, one of them is just 3 patients, just literally small case report. They reported a good results after doing one side and staged the second one. And the other one is a little bit larger, says 14 patients, and again, they staged it intentionally for the bilateral cleft to do it in 2 stages. This article discussed already, Dr. Lehman, Dr. Murthy's survey from 240 ACPA teams. There's some consensus was found among the teams. So some stuff are done same among the teams. 90% of the centers they do secondary alveolar bone grafting. They prefer to do it secondarily. 78% of the teams, they do it at the age of 6 to 9. Again, we now know that it's better to be done based on the tooth, what tooth we are trying to address or save. And iliac crest is the common site for the bone grafting, 83% of the time. But there are some areas that there was no consensus among the teams. Criteria for the timing, follow-up x-rays or the healing guidelines or healing evaluations, and management of the missing tooth, there was some stuff that there was no consensus among the people. Alveolar bone grafting talk is not going to be complete if we don't mention about GPP, but since it's not a talk, I'm just going to mention 2 articles that are large series. One is Dr. Culling's series from 2016. 73% of the people in their study who underwent GPP did not require secondary alveolar bone grafting. GPP alone combined with the secondary alveolar bone grafting, they showed that results in superior bone quality. Unlike the next article that we are going to go over this, this is published in 2009, and the bone quality they showed that was inferior in the patients underwent GPP, and majority of the patients required a secondary, again, another bone grafting. Also, they showed that the bone quality and the growth was restricted with the GPP as well. Alveolar bone grafting harvest from the iliac crest, we all know, just go to take the cortex, cancerous bone from the cortex. I usually close the